Welcome to this series of interviews with the giants of cardiothoracic surgery. My name's Joel Dunning and I'm delighted to be here in Cambridge in the VATS Lobectomy conference with Professor Henrik Hansen. Henrik, it's an absolute pleasure to have you here and it's already been an excellent conference. So I wonder if we could maybe start by, can I ask you, where are we with VATS Lobectomy internationally at the moment?
Well, it's a continuous process, and some of the leading clinics do 80 to 90% of their cases by VATS, and people are following up. And I can see during the years now, I've done VATS lobectomies for over 15 years, that it's a continuous process. But especially the last 5 years, it's really taken off. And I think everybody, if they have to be honest, must agree this is a way to go. And then the next step is really to implant it in every clinic. So I think, at least looking at Denmark, all clinics do offer VATS lobectomy to their patients, and the percentage is of course different from place to place based on experience, but in 5 years' time it will be the standard way to do major lung resections.
How do we get that into our society more? Do we need RCTs, or is the evidence there already?
A good question, and we can discuss that. For ours, I think RCTs will be nice, but we are past that way. And if you have an RCT with maybe a few hundred patients giving conflicting results, it will be questioned heavily because of the amount of evidence, the huge series showing other data now. So I think the setback will be if you have an RCT with 200, 300, 400 patients and the performance of VATS is poor. People will argue or discuss, is it because of the surgeon being poor or not? So, and in my setting, the VATS program had such a huge influence on the whole program of the department, on the fast tracking, on the way we do things, that we cannot step back, we cannot start doing RCTs, we cannot start doing open surgeries again, because by us over 85% of all surgeries is by VATS now.
So we've got VATS lobectomy, it's been going 20 years, but what is the absolute pinnacle, the 2014 best VATS lobectomy we can do? So what is the best?
Well, in my opinion, we have always discussed, and all the papers saying that VATS lobectomy is beneficial for the early stage lung cancer. We should start challenging that, saying, well, if it is beneficial for the people with minimal disease, why should it not then be even more beneficial for people with more advanced disease? And for me, that is the next challenge in looking at where are we going. And I think it should not only for the stage 1, but for the more advanced cases be the standard approach. And the challenge is then the surgeon and not the case of the patient.
So how big's too big? I mean, is 8 centimeter tumor, if you can get behind the vessels, is that still too big? Should you do a thoracotomy?
Well, of course, if you need to put in, the main thing is avoiding rib spreading. And if you need to put in a rib spreader to take out the tumor, of course you can do that incision and do it. But again, when I now and then do open surgery, I miss the vision I have by VATS. I'm totally adapted to this 2D vision, although I can do 3D things. And I see a lot more. You have the 5mm structures and 3mm structures blown up on your screen. And I think that the surgery is much more precise and detailed when you do it by VATS. So actually, I prefer doing it as much as possible. There might, for safety reasons, be some major tumors where you need to have proper control of the vascular structures of the heart and things like that you need to do open, but else the limitation is really your skills and not the patient.
So peripheral ones I think are easy, but I have trouble, with central tumours. I mean, central in the hilar structures. They're the ones I'm still worried about. Are there any good tips, or is it experience?
Tips and tricks, and you can learn in a symposium like this one.
Yeah.
For me, we do the downstage patients. We do patients with former inflammatory disease, tuberculosis, and so on by VATS. But for me, the trick is to do a proper hilar dissection and identify all the structures before you start dividing things. So I do always begin with open the hilar pleura, take the lower ligament. Even if I do an upper lobe, I always take the lower ligament, identifying the vein for the lower lobe, and see all the structures, and then maybe remove some lymph nodes, and if I'm in suspicion of inflammatory disease or, as I said, downstage patients, I use energy-based devices to do all the dissection so I avoid bleeding and I'm in control. I like to see surgery, and especially the VATS surgery, also as a chess game. You have to plan a few steps ahead. You know, just, well, I do this, and what's next? No, you have to have a precise plan, visualize the anatomy, and have plan in your head what is the next few steps, so you are before the problems and not after the problems.
And is it still a benefit if it's into the chest wall, or is this just doing it because we can?
Well, good question. I think in some cases it is beneficial. I've had a few cases where actually not a super tumor, but lower down in the chest wall, I could do a reprosection from inside. I could even put in a Gore-Tex plate, stitch it from inside. So I kept the latissimus dorsi, the muscle, the skin intact where I did the resection, so the patient didn't need to have that, and you can pull the resected ribs in the endo bag and pull it out together with the lobe. So in that way you avoid an incision, avoid muscle spreading at the chest wall, and you keep the outer part of the chest wall intact even though you have done a rib resection.
And Pancoast tumours, do you ever dissect it by VATS first and then open up, or is that again a little bit too far really?
Well, now we're really talking frontline. It is not done as a standard, but actually sometimes if you have a lobe, an upper lobe really fixed to the superior part of the chest wall, it's quite easy to do the lobectomy essentially, because you can do all the hyaline structures, and it's like somebody's lifting up the lobe. So you might end up doing the dissection of the hyaline structures, the lymph nodes, and you leave the lobe there on the chest wall, and then afterwards you can make a limited incision where you need to pull out the tumor and need to pull out the ribs, and do that from outside. So you can say it's a hybrid or a combined procedure. It's been done in a few cases, and that is something we will see more and more often in the next years.
And I've never quite got to sleeve resections. Do you think again that's a very small part of what we do, or maybe carcinoids, are they a suitable person for sleeves?
We do a few sleeves by VATS. First of all, I'm saying that I at any point prefer to do an open sleeve to do a VATS lobectomy, because I think a lobectomy is really a disease in itself. So any doubt, we will schedule the patient for an open sleeve. But we have done sleeves by VATS. We have done especially resection of bronchial stumps and closure, not just sleeve, but close the bronchus by suturing, and doing young ladies with carcinoids who would like to avoid a thoracotomy by VATS. It can be done, and again, the next step from a technological point of view for the cameras will be 3D, where you not need the glasses, but proper 3D. And stitching with a 3D is really beneficial, and I think stitching by the standard VATS now is difficult, and that's, in my opinion, the only advantage of the existing robotic systems is the 3D for stitching. And when you get 3D as a standard setup for VATS surgery, you can start using that modality a lot more, and then I think that the sleeve resections, at least in some centers, will be a standard thing to do by VATS.
So is that where you see the future going of VATS lobectomy, to 3D cameras allowing us to suture?
I would like to have a 3D camera where I can switch from 2 to 3D, 2D to 3D, because in the standard procedure it's not necessary, and sometimes you get a bit of headache working a long time with 3D. But having the modality, so when I really need to do advanced things or I'm in doubt, I put on 3D and I can use that. So yes, 3D is one of the next steps, and I think we have talked for 10 years now, but we want smaller staplers. But there is a mechanical limitation if you have to put in the clips and you have to put in the modality. I would like to see more energy-based devices or smart devices where you can use that. And of course we will pick up something from the robotic technology, and in some time in the future maybe you have at the table, not sitting on a console, at the table you have small robotic or computer things where you have an arm, or maybe a flexible arm, with several modalities and tips, and then you can say, I have this arm and I put on a clip, I put on energy-based device to device structures, and you do that in the patient. And I see a future, maybe in 10 years, where actually you almost stand with what I would say is a PlayStation console at the table and have intelligent robotic instruments inside. And of course things develops, and have a look at what's going on in gaming, have a look at what's going on on your telly back home. Those things we will see in medicine, we'll see in surgery at some point.
Yeah, absolutely, I totally agree. There's a team in UCL trying to design a camera you can just drop in the chest and stick on the chest wall. It's got to be the way forward, isn't it?
Well, when you have the intestinal cameras that you swallow a pill with a camera and you visualize the whole intestine, and why not just pop in a camera, or maybe my boy, he has a helicopter he can control, and I heard just, I read a paper over in the flight over here that the big hit for Christmas gifts this year will be drones, that people can control themselves. So in the future we will have a small system and you can control it from outside, like my 6-year-old boy can control his helicopter flying around in the garden. You will have a small camera helicopter inside the patient, and you can control it and fix it and take the picture, and it just transmitted wireless out to us. You can maybe have small light chains. It's already on the market. You just drop into the chest wall, so you put in 3 small light chains and they enlighten the whole chest wall, a helicopter camera, and you can do the surgery.
Yeah, well, it's certainly exciting times, isn't it, in VATS lobectomy surgery? So
I think we are in a continuous development, and we do a very good job by VATS now, but this is not the final stage. And I look forward to one day when a young surgeon will come to me and say, well, Henrik, you've done a really good job developing the VATS, but you're a bit old-fashioned. Now we have to do it like this. I look forward for that day.
Yeah, great. Well, it's been absolutely fantastic talking to you. It's a real pleasure, and I look forward to the time when I can drop a drone in Middlesbrough and you can control it from your hospital. That'd be absolutely fab.
It's not that far away.
Yeah, maybe. Well, from myself and everyone at CTS, I'd like to say thank you very much.